All right, so picking up where we left off, we talked about the case on the right. So an older patient with non-inflammatory, um, not, vesiculobullous disease in the dorsal hands with a chronic nature, this being porphyria cutanea tarda, easily could have been in pseudoporphyria. Now let's flip over to the case on the left. This is actually a young patient. So it's a young adolescent, and we're now on the ventral fingers instead of the dorsal fingers. And what we're seeing here are these kind of deep inflammatory nodules. Now, you can't get this from a photo, obviously, but these are very tender for the patient. So we have very tender, very painful, deep inflammatory nodules on the ventral surfaces of the fingers. So here, this is a little bit different. So this isn't vesiculobullous, this is inflammatory. There's no epidermal change. There's no vascular component. It's not vesiculobullous. It's not a purpura, and there's not pigment change. And there's not scalar cross. That's how you know there's not epidermal change. So it's dermal, and then it's dermal inflammatory, and it's very brightly erythematous. So you can sometimes try to make a prediction for what is coming in and causing this type of inflammatory process based on the color. It's not perfect, but general rules are things like granulomatous histiocytic look yellow brown, lymphocytic looks pink, and the neutrophilic looks deeply red. And I would argue, over time, as you train your eyes and kind of learn to look at these, that this is a very deep red. This is violaceous almost. This is very red. So immediately you can have suspicion for neutrophilic. So we have some type of dermal inflammatory neutrophilic process on the ventral surfaces of the fingers in a young child. So you put it right there in a bucket. From there, you might not know, if you haven't seen or haven't learned about this entity, exactly what it is, but you have it right down to the inflammatory bucket. And so I think better than memorizing a bunch of entities, which you will learn over time and experience, it's best to be able to put these entities in a proper bucket, because one day you're going to come across something that you don't know what it is or has never seen it. Maybe it's not even uncharacterized, and you'll be able to put it right where it is and get to the diagnosis. So this has a specific name to it. And what's kind of interesting is this was a telederm that was sent over, and some of the history that was provided to me is that this adolescent plays video games a lot. So this adolescent's using the ventral surface of their fingers, presumably on some type of controller. So now we have the history of repetitive trauma to that area. So knowing that, kind of feeding it into our minds, we have repetitive trauma, dermal inflammatory neutrophilic, tender papillary nodules in the ventral surface of the hands. And this is a known entity, and it's known as eccrine hidradenitis. Another name for it, when it occurs without a clear mechanical trigger, is idiopathic palmoplantar hidradenitis. This is a known entity where basically neutrophils come in and cause inflammation of your sweat glands. You have high density of sweat glands, especially eccrine sweat glands on your palms and soles. So it typically occurs on your palms and soles. Newts come in. Newts cause a lot of inflammation. It causes tenderness and causes pain. And really common in this demographic of adolescents. Now, you might kind of wonder why I'm putting these two cases together. I thought it was interesting that the case on the left was a young person on the ventral surface. The case on the right is an older person on the dorsal surface. But more than that, I want to highlight the differences of the anatomy. So on the dorsal hands, the skin is just normal skin. This is the same skin that you would have on the forearms if you did a biopsy of it. If you do an excision or any types of procedures here, nothing really is too special about the skin. It just happens to be on the dorsal aspect of the hands. Whereas if you look at the skin on the ventral aspects of the hand and then on the soles, this is extremely unique skin, right? So it's glabrous, there's no hair, and then the stratum corneum is extremely thick. The significance is that vesiculobullous diseases and inflammatory diseases on the ventral surface of the hands and on the palms of the soles don't look the same. The reason is the stratum corneum is so thick, it kind of disguises and masks the typical pathology that you see. So something like eccrine hidradenitis or palmoplantar hidradenitis is so inflammatory that if you took these lesions and put it on the dorsal hands rather than the ventral hands, it could even be vesiculobullous. It could cause enough fluid there that it could raise up, or it could be very kind of palpable. The reason why it's so deep set here, deep seated and nodular, is because of the depth and width kind of size of the stratum corneum. So you get these deep seated nodules. So it's a good takeaway to know that when you see something nodular on the palms or the soles, it's probably papular elsewhere. Same with vesiculobullous diseases. I've seen so many cases of SJS or TN or erythema multiforme, et cetera, where on the palms it's pretty bland looking and it's just flat. And so that's why I wanted to highlight this really nice case of eccrine hidradenitis in an adolescent and contrast it to this case of porphyria cutanea tarda in an older patient. Hope you enjoyed this video.